Hi guys, now we are going to start arterial disorders part 1. In this chapter, we are going to discuss peripheral arterial occlusion, embolic occlusion, Buerger's disease, gangrene, amputation, leg ulcers. In leg ulcers, mainly we will be discussing arterial ulcers. After that, we will be discussing AV fistula and thoracic outlet compression syndrome. So let's start. First tell me, what is the problem in peripheral arterial occlusion? So if there is arterial occlusion anywhere in the body, it leads to ischemia. And if ischemia is occurring anywhere in the body, what is the manifestation? Pain. So because of peripheral arterial occlusion also, what happens? There is pain. Not only pain, actually it is characterized by 5 P's. Peripheral arterial occlusion, it is characterized by 5 P's. So what are those 5 P's? There is pain, pallor, there is paresthesia, paralysis and pulselessness. So first question which we discussed, that out of these 5 P's, the 6th P is sometimes poikilothermia. Sometimes there is a 6th P, and what's that? This is poikilo. So this is poikilothermia. The 6th P, that is poikilothermia. Clear? So mainly it is 5 P's. Can you tell me which one is the most common manifestation of peripheral arterial occlusion? Yes guys, it is pain. So most common, it is pain. Right? There is pallor, there is paresthesia, paralysis, pulselessness. One classical example, imagine patient is having compartment syndrome. How much is the pressure in compartment syndrome? More than 30 mmHg. Because of that, what will happen? In the compartment, there is compression of vessels. So the patients who are having compartment syndrome, which one is the late sign? In patients of compartment syndrome, pulselessness, it is late sign. This question was asked in both FMG and NEET PG. Pulselessness, it's a late sign. And which one is associated with worse prognosis? Yes, paralysis. So which one is associated with worse prognosis? It is paralysis. It is paralysis. So these are 5 P's, sometimes the 6 P's, poikilothermia. So these are 5 P's of peripheral arterial occlusion. Next question, tell me what is the most common cause of peripheral arterial occlusion? And you know, it is atherosclerosis. Atherosclerosis, it is one of the most common causes of most of the conditions in arterial disorders. Let me discuss. Like, it is the most common cause of peripheral arterial occlusion, most common cause of extracranial aneurysm, most common cause of subclavian artery stenosis, and it is the most common degenerative disorder of vessels. So question, what is the most common cause of peripheral arterial occlusion? That is atherosclerosis. And if you're talking about young male smokers aged less than 40, then one of the common causes, Buerger's. Apart from atherosclerosis and Buerger's, it is also seen in Takayasu arteritis, also seen in the patients who are having SLE, systemic lupus erythematosus. It is seen in post-traumatic cases also, and radiation injury can also lead to peripheral arterial occlusion. You tell me, what's the cause? You know that whenever you give radiotherapy, what happens? There is obliterative end arteritis. And if there is obliterative end arteritis, what will happen? Yes, obviously there is occlusion. So radiation injury, it leads to obliterative end arteritis. Clear? So it leads to obliterative end arteritis, and because of this obliterative end arteritis, what will happen? Yes, there can be peripheral arterial occlusion. So these are the causes. Most common, that is atherosclerosis. So let's compare atherosclerosis and Buerger's disease. First, out of atherosclerosis and Buerger's disease, relatively, which one is more common? So it's the atherosclerosis which is more common in comparison to Buerger's disease. In which particular age group atherosclerosis is seen? 6th to 7th decade. But if you see Buerger's, which is also known as thromboangiitis obliterans, in short, it's known as TAO. Thromboangiitis obliterans, exclusively it is seen in young males, smokers and age less than 40 years. So exclusively seen in young male smokers age less than 40 years. Next, which vessels are involved by atherosclerosis? You know, there is involvement of aorta, iliac artery, femoral popliteal. It means involvement of large and medium-sized vessels. So mainly, atherosclerosis is going to involve large. So it is going to involve large plus medium-sized vessels. Clear? So there is involvement of large plus medium-sized vessels. Medium-sized vessels. Aorta, iliac artery, femoral and popliteal. But if you see Buerger's, it is going to involve small and medium-sized vessels. So here, there is involvement of small and medium-sized. So here, in Buerger's, there is involvement of small and medium-sized vessels. Now guys, tell me which vessels are involved in Buerger's and how to remember. Mnemonic is TPR, T, tibial, P plantar, R radial. So how to remember? Mnemonic is TPR, it is tibial. So this is tibial, it is P plantar. So this is tibial, plantar and radial. So there is involvement of tibial, plantar, radial, right? Next, tell me, atherosclerosis is going to involve upper limb or lower limb? So mainly it is seen in lower limb. In Burgess, you can notice that there is involvement of radial artery also. And since there is involvement of radial artery also, what happens? It is seen in both lower limb as well as upper limb. It is more common in lower limb. So what? It is more common in lower limb, but it can be seen in upper limb also. So these are the differences. So guys, suppose a patient is having gangrene of toe, and patient is a chronic smoker, which is the risk factor for both atherosclerosis as well as Burgess. But the age is 6 to 7 decade. Obviously, the cause is atherosclerosis, and if the age is around 40, obviously it is Burgess disease. Now see, the manifestations in cases of arterial occlusion, it depends on the site of occlusion. So manifestations are dependent on the site of occlusion or site of obstruction. Imagine, where is the obstruction? Imagine here is the obstruction. So you can notice that obstruction is at aorto-iliac bifurcation. Can you see here? So obstruction is at aorto-iliac bifurcation. And whenever there is obstruction at aorto-iliac bifurcation, what happens? The blood supply to both limbs are affected. The blood supply of internal iliac as well as external iliac, both of these are reduced. So because of this aorto-iliac obstruction, patient will be having claudication. What is the cause of claudication? Claudication is because of ischemia of muscles. So claudication is because of ischemia of muscles, and obviously ischemia will occur distal to obstruction. So whenever patient is having aorto-iliac obstruction, in this case, they will be called claudication in the buttocks, thighs and calves, obviously bilaterally. Femoral and distal pulses, obviously, these will be absent in both limbs. So femoral and distal pulses absent in both limbs. Bruit, since obstruction is at aorto-iliac bifurcation. So there is aorto-iliac obstruction. So obviously there will be bruit at aorto-iliac region. So where is the bruit? Bruit is at aorto-iliac region. Aorto-iliac region. Okay. Another important point, you can see what is the name of this artery? This one. This is internal iliac. Whenever obstruction is at aorto-iliac bifurcation, yes, internal iliac blood supply is also affected, and that also bilaterally. Now see, erection and ejaculation. Erection is because of parasympathetic system. Ejaculation is because of sympathetic system, right? So at the time of erection, there should be increased blood flow to the penis. But whenever there is obstruction at the level of aorto-iliac bifurcation, the penis blood flow is affected. So at the time of erection, sufficient amount of blood is not going to the penis. So what will happen if there is aorto-iliac obstruction? These patients will be having erectile dysfunction. And guys, this is one of the very important question. What is the name? Leriche syndrome. So this is erectile dysfunction. Erectile dysfunction. Right? So one of the common cause of erectile dysfunction, what? It is atherosclerosis, and you know, smoking is a risk factor for atherosclerosis, right? So people who are having this erectile dysfunction, that is impotence, they are not able to penetrate the vagina. And that's why what happens, you have seen the ads whenever you are traveling by bus, by train, you have seen on the walls big ads, mile, kamjor rogi mile. This kind of patient contact, yes, all these kind of things. See, the things are not going to improve. Why? If there is occlusion and until and unless some revascularization procedure is done. If it is because of aorto-iliac obstruction, okay? Right? So this is aorto-iliac bifurcation obstruction, and one of the manifestation which is not seen in other obstructions, that is Leriche syndrome. This is erectile dysfunction or impotence. Next, suppose obstruction is at the level of iliac artery. Here you can see if there is iliac obstruction, right? In this case, again, there will be claudication unilaterally, where in thigh and calf, but it's unilateral. Similarly, the femoral and distal pulses will be absent in the affected limb. So obviously unilaterally in the affected limb. And where is the bruit? Bruit is over the iliac region. You can hear the bruit over iliac region. So bruit, it's present over, you can hear the bruit over iliac region, over the iliac region, right? Third, if patient is having femoropopliteal obstruction, you can see there is femoropopliteal obstruction. So where is the claudication? Obviously in the calf, again It's unilateral, means in the affected limb only. Femoral pulses here. Femoral pulses are palpable, but distal pulses are absent and obviously unilaterally. So femoral pulses, since obstruction is distal, so femoral pulses, these are palpable, but the distal pulses, these are absent, obviously unilaterally. These are absent and that unilaterally, right? If there is distal obstruction, means beyond femoropopliteal obstruction, if obstruction is there, so here you can notice that there is distal obstruction. In this case, there is claudication in calf and foot, again unilaterally. Femoral and popliteal pulses, obviously both of these are palpable. Both of these are palpable, but the ankle pulses, since obstruction is proximal to ankle, what? It's absent. So ankle pulses absent and obviously unilaterally. Unilaterally, guys, I'm repeating the question. The question, mostly they ask this question when the obstruction is at aortoiliac bifurcation, or it is aortoiliac obstruction and one of the manifestation is impotence, erectile dysfunction or Leriche syndrome. Next is embolic occlusion. See, embolus is one of the important cause of arterial occlusion. What is embolus? It is detached thrombus from heart or more proximal vessels. Can you tell me what is the most common source of embolus? Yes, it was discussed in medicine multiple times. Guys, it is left atrium. Why? Because these patients are having atrial fibrillation. So the most common source, that is left atrium. Most common source, it is the left atrium. Which patients? These patients are actually having atrial fibrillation. So that's the most common source. Can you tell me what is the second most common source? It's the mural thrombus. In which patients? The patients who are having MI, myocardial infarction. So second most common source, that is mural thrombus. Mural thrombus. In which patients? Yes, the patients who are having MI, myocardial infarction. So mural thrombus in the patients who are having MI. That is the most common source, left atrium followed by mural thrombus. Next, what happens? The manifestation of embolic occlusion depends on the organ affected. Suppose it is in one of the branches of carotids. Yes, so it is in the arteries which is supplying the brain. In that case, what happens? These patients are having transient ischemic attacks or stroke. You have seen multiple cases. So what? If there is embolic occlusion in the vessel supplying the brain, there can be transient ischemic attack or it can lead to stroke. Right? If there is involvement of vessels supplying the retina, in that case, there is amaurosis fugax. So it can lead to amaurosis fugax. Can you tell me what is this amaurosis fugax? Here, there is temporary loss of vision due to lack of blood flow to the retina. Imagine there is embolic occlusion to mesenteric vessels, and you know, one of the most commonly involved vessel is superior mesenteric artery. And whenever there is embolic occlusion to superior mesenteric artery, it leads to acute mesenteric ischemia. It leads to acute mesenteric ischemia, and because of acute mesenteric ischemia, if treatment is not provided properly on time, it can lead to ischemia leading to gangrene of small bowel. So because of acute mesenteric ischemia, if treatment is not provided early, it can lead to ischemia and gangrene. So it can cause ischemia and gangrene of small bowel. Gangrene of small bowel or small intestine. If suppose there is embolic occlusion of one of the branches of splenic artery, what will happen? There is splenic infarction, and because of this, patient will be having what? Local pain. So because of embolic occlusion of one of the branches of splenic artery, there is local pain. Why? Because it can cause splenic infarction. And whenever it is in one of the branches of renal artery, it can lead to loin pain. It can cause hematuria. So it can lead to loin pain and hematuria. Okay, so what did you see here, guys? You saw that what? The manifestations are dependent on the organ affected. Means the blood vessels which are going to supply the organ. Yes, if that is occluded, obviously the manifestation depends on the organ affected. Now, patients who are having embolic occlusion, actually it's emergency. We have limited time. So we have to make the diagnosis and we have to treat the patient. So in majority of cases, the diagnosis is made clinically. So it's the clinical diagnosis. How you're going to make the clinical diagnosis? First, by the manifestations. First, look for the source of embolus. If patient is having atrial fibrillation, if patient is having myocardial infarction, so there is a source of embolus. Yes, left atrium or mural thrombus. Second, patient should not be having history of claudication. So there is a source of embolus and there is no history of claudication. Because of this, patient is having severe pain and numbness in the limb. Because of embolic occlusion, the movement becomes difficult, painful, and if there is occlusion, what happens? The distal pulses are not palpable. So it's the clinical diagnosis. Obviously, since it's an emergency situation, we have to make the diagnosis on the basis of clinical manifestations. When the diagnosis is done, after that we have to start IV heparin. We have to give 5,000 units of IV heparin. What is the role? First, it is going to reduce the extension of thrombus and it maintains the patency of vessel. So, reduce the extension of thrombus and maintains the patency. Right? After that, what? You have to attempt, if there is embolus, embolectomy, and if there is formation of thrombus, go for thrombectomy. Embolectomy or thrombectomy? First question, guys, you tell me. This was an image-based question also. Which catheter is used for embolectomy or thrombectomy? And what's the name? It is Fogarty balloon catheter. How to identify? You can see here. This is a long catheter and you can see how to identify. There is a balloon at the tip. So this is Fogarty balloon catheter. Right? Now, how to use this Fogarty balloon catheter? See this image. In this image, you can notice that this is thrombus or embolus. Right? We are going to insert this Fogarty balloon catheter and the balloon is in deflated state. After that, what? You are going to insert it. So, Fogarty, it is inserted through the embolus, beyond the embolus. And after that, what? This is the balloon. Inflate the balloon and withdraw the catheter. So, when you inflate the balloon and you withdraw the catheter, what? You can see that this thrombus or embolus come out, right? So, this is embolectomy if there is embolus, thrombectomy if there is thrombus. Name of catheter? Fogarty balloon catheter. Next is Burgess disease. We already discussed what is the other name. It is also known as tau. Thromboangiitis obliterans. Tau, that is thromboangiitis obliterans. So, can you tell me the three components? Thromboangiitis. So, what happens? There is thrombosis. Thrombosis. After that, angiitis. Angiitis means inflammation of artery. So, what happens? Thrombosis, angiitis, and finally, what will happen? There is obliteration. Obliteration means occlusion of vessel. Obliteration. So, just break it. There is thromboangiitis, obliterans, thrombosis, angiitis, and obliteration. It is segmental inflammatory disease. Here, there is involvement of, we discussed which vessels, tell me? Small and medium-sized vessels. So, it is going to involve small and medium-sized vessels. Small and medium-sized, guys, and we discussed that. Medium-sized vessels, right? We discussed that. What are the arteries involved? Vessels involved. Mnemonic is TPR. And what was the mnemonic? Tibial plantar radial. So, you can see there is involvement of tibial plantar radial. Involvement of tibial plantar radial. Again, another important point that it is exclusively seen in young males smokers. Exclusively seen in young males smokers. So, it is not seen in females. Exclusively seen in young male smokers age less than 40 years. So, what's the age here, guys? Less than 40 years. And see, suppose this is the lower limb of the patient, right? What is the progression? Since it is going to involve small and medium-sized vessels, see the progression from distal to proximal. Second, in between, there are skip lesions also. Skip lesions also. So, if distal vessels are affected, there are skip lesions also. That's why here, revascularization procedure is not very helpful. Why? Because distal vessels are occluded. So, what is the progression? You have to remember progression. It is from distal to proximal. Progression is from distal to proximal. Proximal. So, from distal to proximal, since there is involvement of distal vessels are occluded. That's why revascularization procedure, it is not very helpful. Another important point, it is associated with skip lesions. Associated with skip lesions. Okay. Next, important point. You have heard in anatomy that neurovascular bundle. There is neurovascular bundle. So, you are going to notice that artery, nerve and vein. Artery, vein and nerves, all of these three are going to travel together usually. So, since there is neurovascular bundle, just notice that this is a vein here. This is an artery. Clear? And this is a nerve. This is a nerve. Clear? So, this is neurovascular bundle. What happens? In thromboangiitis obliterans, initially, there is inflammation of what? Arteries. But whenever inflammatory process is going to extend beyond arteries, what happens? It is going to involve all three structures. So, initially, it is in the arteries, but ultimately, it is going to involve all three structures. So, important point that inflammatory process ultimately involves all three structures. What? artery, what? Vein, nerve. So ultimately it involves all three structures: artery, vein and nerve, and this question is asked in pathology also, right? Next, what is the triad? It is characterized by a triad. There is Raynaud's phenomena, intermittent claudication, migratory superficial thrombophlebitis, and how to remember? Mnemonic is RIM. Guys, so it is characterized by a triad, mnemonic is RIM, Raynaud's phenomena, intermittent claudication, migratory superficial thrombophlebitis. What is intermittent claudication? We discussed that it is because of ischemia of muscle. Muscle ischemia occurs during walk or during exercise. So during work or during exercise, ischemia of muscle is going to occur. So whenever patient is going to walk, patient is doing some kind of exercise, patient is having crampy pain. And usually it is seen that fairly the claudication distance remains constant, fairly. So what happens? If patient is going to walk for a certain distance, patient start having intermittent claudication. So initially it's fairly constant, but when disease is going to progress, what happens? The claudication distance also decreases. So it means the claudication distance is also going to progress. So that is intermittent claudication. It is because of ischemia of muscles. So that's why it is more prominent during work or exercise. Patient is busy doing work or exercise during daytime. So that's why indirectly patient will be telling you that these symptoms are more common in daytime, not in night, because in night patients are taking rest. And we discussed that fairly this claudication distance remains constant. Later it is going to progress. So there was one question in latest exam that what is the classification system for grading of intermittent claudication? And guys, the name, it is Boyd's classification. So what is the name? It is Boyd's classification. What is grade 1? When patient starts the walk, what happens? Pain appears. So pain appears at the beginning of walk or at the start of walk, but disappears if patient continues to walk. Why? Because initially there is collection of substance P. When patient continues to walk, the substance P collected is washed away because of increased blood flow. Next, grade 2. In grade 2, patient can walk with pain. Patient can walk. Patient can walk with pain. Patient can walk with pain. Grade 3, here, pain compels the patient to take rest. So what happens? Patient is going to walk for a certain distance. After that, patient is going to take rest. After that, patient is going to walk for certain distances. So what? Grade 3, pain compels the patient to take rest. Pain compels the patient. Pain compels the patient to take rest. To take rest. Clear? And obviously, what is grade 4? You know that grade 4, it is rest pain. So grade 4, that is rest pain. Rest pain, you have to remember this is Boyd's classification, is the grading of intermittent claudication. Next, what is the cause of rest pain? Whenever there is progression of symptoms, see guys, it is because of cutaneous ischemia. What happens here? There is sympathetic stimulation. Sympathetic stimulation causes vasoconstriction, and whenever there is vasoconstriction, there is cutaneous ischemia. So rest pain, it is because of cutaneous ischemia. Rest pain, it is because of cutaneous ischemia. And this cutaneous ischemia, it is because of what? Sympathetic stimulation. And that's why we will be discussing in the treatment that we can perform lumbar sympathectomy if patient is having rest pain. Now see the typical history. Usually these smokers are manual laborers or workers. Manual laborers or workers, they have break after 3 hours, 4 hours of work. And whenever they have break, somebody is, start making kani. Somebody is going to eat gutka. Somebody is going to smoke bidi, not cigarette, bidi. What happens? Because of this chronic smoking behavior, what happens? They have thromboangiitis obliterans. During daytime, this patient is busy. That's why patient is not going to appreciate the pain. During night, after dinner, when patient is going to sleep, patient is having pain. So what happens? Patient is sitting in the bed, hanging the legs by side of bed, so that by gravity, some amount of blood should be reaching the ischemic areas. And we have seen these patients who are addicted to smoking, yes, they are going to smoke bidi throughout the night. So what happens? Rest pain. In the night, patient is hanging the legs by the side of bed. Why? Because there is some improvement in the pain, improvement in the symptoms. Why? Because of gravity, the blood is going to the ischemic areas. That's why there is partial relief. Ultimately, what will happen? There is gangrene. And what is the progression? We discussed that. It is going to involve small and medium-sized vessels. So progression, it is from distal, and it is proceed to proximal region. So gangrene, it is going to progress from distal and then it is going to proceed to proximal region. So initially patients are having gangrene of toe and further it is going to involve the foot. It can reach up to below the knee. So sometimes in exam, question is asked in relation to intermittent claudication, which is because of occlusion of vessel. So this is also known as vascular claudication. So intermittent claudication, it is because of occlusion of artery. Because of that, there is ischemia of muscle. This is also known as vascular claudication. Similar manifestation is also seen in the patients who are having lumbar canal stenosis. That's why what's the name? Pseudo-claudication or neurogenic claudication. So first tell me, what is the cause of this neurogenic pseudo-claudication? It is because of lumbar canal stenosis. It is because of lumbar canal stenosis. First important point. Second, so what is this intermittent claudication? It's the cramping pain after walking for certain distance. In majority of patient, the walking distance is fairly constant. That is known as claudication distance. What are the provoking factors for intermittent claudication? When your muscles are working or exercising. So walking, exercise, up and incline, when patient is going up and incline. But for neurogenic pseudo-claudication because of lumbar canal stenosis, again, walking and exercise are provoking factors, but symptoms can be seen even if patient is standing still. And here, if patient is going down and incline, walking distance, it is fairly constant in intermittent claudication. So that is claudication distance. It is fairly constant. And here, in pseudo-claudication, it is variable. It is variable because it is related to lumbar canal stenosis. Distal pulses, obviously in vascular claudication, the distal pulses are reduced because it is because of vascular occlusion, and pulses are normal if it is occurring because of lumbar canal stenosis. So in lumbar canal stenosis, the pulses are normal. So this is the difference between vascular claudication and pseudo-claudication, that is neurogenic pseudo-claudication. Now guys, what is the investigation of choice for diagnosis? In Burgess disease, the investigation of choice for diagnosis, it is duplex. This is duplex. What is the advantage of duplex? First, it will tell you the site of occlusion and it will tell you the reduced flow. So what? You can detect the site of occlusion and you can notice that there is reduced flow. So it is duplex, right? Suppose we are going for angiography. Whenever patients are having Burgess disease, since it's a chronic process, occlusion is occurring over a long period of time, so there is formation of collaterals. So if you perform angiography in Burgess disease, you can notice that this kind of collaterals are seen. So what's the name? Corkscrew collaterals. This was asked in one of the latest exam. So what? Burgess disease on angiography. Which investigation? Burgess disease on angiography. There is corkscrew collaterals. What? Corkscrew collaterals. So there are corkscrew collaterals. And if patient is having Budd-Chiari syndrome, what is the cause? Budd-Chiari syndrome, it is caused by hepatic venous outflow obstruction because of hepatic vein thrombosis or IVC occlusion. In this case, we are going for venography because the problem is in the vein. Venography. And on venography, what kind of collaterals are there? Spider web collaterals. So here, there are spider web. Venography, these patients are having spider web collaterals. So guys, you have to remember, yes, corkscrew collaterals in the patients of Burgess, investigation angiography, Budd-Chiari syndrome on venography, spider web collaterals. Next is ankle brachial pressure index. What is ankle brachial pressure index? So we are going to assess the ratio of systolic blood pressure, where ankle means at the ankle, and in the brachial artery, where exactly? In the arm. In arm, in which artery? In brachial artery. In brachial artery. So it is ratio of systolic blood pressure at ankle and in the arm in brachial artery. Now tell me, usually it should be more than 1 or less than 1. See, because of effect of gravity in the lower limb, usually the pressure should be more. So that's why if you are taking systolic blood pressure at ankle, obviously it should be relatively more than systolic blood pressure in the brachial artery. So ideally, it should be more than 1. Even if it's equal to 1, it's fine. But if it's less than 1, it means there is occlusion. This ankle brachial pressure index is given in the Bailey also, but complete information is not given. Now, we are discussing this complete information. Yes, there are certain errors also. So, imagine if the ankle brachial pressure index is more than 1.4, it is suggestive of, yes, that vessel is non-compressible. Why the vessel is non-compressible? Because it is calcified. So what happens? It is suggestive of calcified vessels. It is suggestive of calcified vessels, and can you tell me what's the cause? It is because of diabetes mellitus. Diabetes mellitus or end stage renal disease. 1 to 1.4, this is normal. 1 to 1.4, that's normal. If it is 0.91 to 0.99, 0.91 to 0.99, it is borderline. And if it's borderline, further diagnostic testing is suggested. So it is borderline. In these cases, further diagnostic testing is suggested. If it is 0.5 to 0.8, in Bailey it's written less than 0.9. So it is 0.5 to 0.8. Here, patient is having intermittent claudication. So patient is having intermittent, right? Patient is having intermittent claudication. Clear? It means if it is between 0.5 to 0.8, patient is having hemodynamically significant arterial occlusion. Hemodynamically significant arterial lesion or occlusion. And if it's between 0.1 to 0.4, guys, patient is having critical limb ischemia, that is also known as critical limb ischemia, also known as CLTI, that is chronic limb threatening ischemia. So CLI, critical limb ischemia, or CLTI, which is mentioned in the Bailey, it is chronic limb threatening ischemia. So this is the interpretation. Now let me discuss the questions. First, they ask this question. If the value is more than 1.4, it is suggestive of calcified vessels. First. Second, what is the value when patient is having intermittent claudication? Less than 0.9, so that is 0.5 to 0.8, and in which cases there is CLTI or CLI. Yes, whenever it is less than 0.5, that is 0.1 to 0.4. So this is ankle brachial pressure index, also known as ABI or ABPI. There is a similar investigation known as toe brachial pressure index. You know, toe arteries or digital arteries, these are rarely affected by sclerosis. Advantage, that toe arteries or digital arteries, these are rarely affected. These are rarely affected by sclerosis. So these are rarely affected by sclerosis. Clear? So if we are going to combine toe brachial pressure index and ankle brachial pressure index, it is more reliable diagnostic tool. It is more reliable diagnostic tool for detection of large vessel steno-occlusive disease in diabetes mellitus. So this one is more reliable diagnostic tool for detection of large vessel steno-occlusive disease, stenosis and occlusion. So this is steno-occlusive disease in patients of diabetes mellitus. Clear? And whenever TBI, that is toe brachial pressure index, is less than 0.6, it is suggestive of significant arterial lesion. So guys, you have to remember, it is suggestive of significant arterial lesion. Clear? There is significant arterial lesion. Significant arterial lesion. So that is toe brachial pressure index. Another investigation which is very helpful, that is digital subtraction angiography, also known as DSA. So first question, it's a type of angiography. Here you have to inject the dye. Where we are going to inject the dye? The dye is injected in common femoral artery using Seldinger technique. So dye is injected in common femoral artery using Seldinger technique. Using Seldinger technique. Seldinger technique, right? Why it is known as digital subtraction angiography? Because here digital, so here the images are digitalized by computer. Why it is known as subtraction? Because extraneous background like bone and soft tissues, these are subtracted. So these are removed, providing the clearer images. And what is the benefit of DSA? It is going to provide dynamic arterial flow information. It is going to provide dynamic arterial flow information. Dynamic arterial flow information. See, in all cases, this information is not required. Second, since there are complications of DSA, what are the complications? Since you are going to puncture the common femoral artery, it can lead to bleeding, there can be hematoma, there can be thrombosis, there can be false aneurysm formation, arterial dissection, or digital embolization. Second, you are going to inject the dye or contrast. Because of this dye or contrast, patient might be having renal dysfunction or allergic reaction. So in all cases, we are not going for DSA. It is done when intervention is planned. So whenever intervention is planned, DSA is done. Indication, whenever intervention is planned. It is done whenever intervention is planned. So that's the indication. Next is Fontaine's staging of limb ischemia. This is Fontaine's staging. So it is going to signify how the disease is going to progress. If it is stage 1, these patients are actually asymptomatic. So in stage 1, patients are asymptomatic. Asymptomatic. If patient is having mild intermittent claudication, it is stage 2A. Here, patient is having mild intermittent claudication. But if patient is having moderate to severe intermittent claudication, this is 2B. Stage 2B here, patient is having moderate to severe. So these patients are having moderate to severe intermittent claudication. Stage 3, these patients are having rest pain. And what happens in stage 4, guys? Here, patient is having critical limb ischemia. And what will happen? This critical limb ischemia, it is going to progress, or it can lead to ulceration and ultimately gangrene. So it can progress to ulceration. So it can progress to ulceration and ultimately gangrene. So it can progress to ulceration and gangrene. Now treatment, first and most important thing, abstinence from smoking. Smoking is very addictive. Let me share you one story. We had one patient who was having Burgess disease and below-knee amputation was planned. Right? What happened? He went outside in the park around 4 a.m. in the morning and he smoked bidi. And this case was the first case in the OT. So whenever that case was on the OT table, anesthetists were there and they detected that what? Yes, because the smell was coming, they detected that patient smoked and case was cancelled, right? So can you believe? On the day of surgery also, patient smoked a bidi in the morning. So what? First thing, that there should be abstinence from smoking. Abstinence from smoking. Vasodilators are helpful, but it is not very effective. What are the vasodilators we are using? One is xanthinol nicotinate. Agents which we are using, that is xanthinol nicotinate, right? It comes with the brand name of Complamina, right? And second is Trental. The brand name is Trental and the agent name is pentoxifylline. What's the name? It is pentoxifylline. Pentoxifylline, brand name is Trental. So xanthinol nicotinate and pentoxifylline. Second, lumbar sympathectomy. We discussed the physiology that muscle blood supply is not under sympathetic control. So lumbar sympathectomy is not done for intermittent claudication. The skin blood supply is under sympathetic control. So whenever there is sympathetic stimulation, there is cutaneous ischemia. Because of cutaneous ischemia, there is rest pain. So for which indication we are performing lumbar sympathectomy? Yes, lumbar sympathectomy is done for rest pain. One of the other treatment option is omental transposition around the arteries. And if patient is having gangrene, you can see in this image, patient is having gangrene. For gangrene, we have to go for amputation. For gangrene, we go for amputation, right? Now let me discuss the question which was asked in one of the latest exam. And most of the students marked wrong answer. See, chronic smoker, age 65 years. So chronic smoker male, age 65 years, what? Presented to you with gangrene. Can you see? Gangrene of toe. What is the cause? Most common cause. Obviously, the most common cause of peripheral arterial occlusion, it is atherosclerosis. So if age, it is 6th to 7th decade, it is atherosclerosis. What's the cause, guys? It is atherosclerosis. Atherosclerosis. But if patient is young, age around 4th decade, this is Buerger's. Buerger's. Clear? So guys, look at the age. If it is around 6th to 7th decade, it's because of atherosclerosis. If it is around 4th decade, it is because of Buerger's. So we discussed lumbar sympathectomy. What is the indication of lumbar sympathectomy? In Buerger's disease, rest pain, we discussed. Clear? Rest pain. Yes. What are the ganglias removed? We are going to remove L1 to L4. So in lumbar sympathectomy, we are going to remove L1 to L4 ganglia and on affected side. So on the affected side, L1 to L4 ganglia is removed, right? But imagine, we have to perform bilateral lumbar sympathectomy. In that case, at least L1 should be preserved on one side. Tell me why. Why at least L1 should be preserved on one side? Okay, let me tell you, it's very, very easy. We discussed that erection is because of parasympathetic system, ejaculation is because of sympathetic system. So you can see here, at the time of ejaculation, what will happen? At the time of ejaculation here, there is one sphincter. near bladder neck. What's the name? This is internal urinary sphincter, right? This is under sympathetic control, under L1 sympathetic ganglia. It's a smooth muscle. So whenever there is sympathetic stimulation, there is ejaculation. What happens? This sphincter is closed, so that most of the semen, it is going, out via urethra. So semen is going out via urethra. What is the big problem? If you are going to remove L1, in that case, what will happen? Since this internal urinary sphincter is not closed, in that case, you can notice that the semen will also go in the bladder. And whenever the flow is against, whenever it is going against the flow, this is known as retrograde. So semen is entering into bladder. This is retrograde ejaculation. So what are the other conditions in which retrograde ejaculation can be seen? TURP. Because in TURP, there is no proximal landmark. There is increased risk of injury of internal urinary sphincter. If you give alpha blockers, why? Because this internal urinary sphincter, this is smooth muscle. This is smooth muscle, and because of alpha blocker, what will happen? There is smooth muscle relaxation. So what are the causes of retrograde ejaculation? Yes, whenever you are performing bilateral lumbar sympathectomy with removal of bilateral L1 ganglia. TURP, because there is injury of internal urinary sphincter. Alpha blockers, because it is going to relax the sphincter, because it is going to relax the smooth muscle, and internal urinary sphincter is a smooth muscle. So that's why when you plan bilateral lumbar sympathectomy, at least L1 should be preserved on one side to prevent retrograde ejaculation. Why? To prevent retrograde ejaculation. When we are performing lumbar sympathectomy, sometimes there are structures which are mistaken for lumbar sympathetic ganglia. And at the place of lumbar sympathetic ganglia, those structures are removed. So what are the structures which are accidentally mistaken for lumbar sympathetic ganglia and removed? How to remember? The mnemonic is GPL, that is Gujarat Premier League. G, that is genitofemoral nerve. P, psoas sheath, psoas minor. So the muscle is psoas. So psoas sheath, psoas minor. So it is psoas sheath, psoas minor, and L, lymphatics, right? So L, that is lymphatics. So genitofemoral nerve, psoas sheath, psoas minor, and lymphatics. These are the structures mistaken for lumbar sympathetic ganglia and accidentally removed during lumbar sympathectomy. Apart from Buerger's disease, rest pain, what are the other indications of lumbar sympathectomy? We discussed the physiology. So any situation in which there is sympathetic stimulation, in that case, it will be helpful. So what are the indications? Buerger's disease. Buerger's, especially for the rest pain. So it is Buerger's disease, especially rest pain. Atherosclerosis, Raynaud's disease, acrocyanosis. So Buerger's, atherosclerosis, Raynaud's disease, acrocyanosis, Koszalgia, hyperhidrosis, erythrocyanosis, frostbite. So how to remember, guys? The mnemonic is Barashef. So what? Mnemonic Barashef. Barashef, Buerger's, atherosclerosis, Raynaud's disease, acrocyanosis. C, Koszalgia. H, hyperhidrosis. E, erythrocyanosis. F, frostbite. But remember, intermittent claudication is not an indication for lumbar sympathectomy because the blood supply of muscle is not under sympathetic control. Next is gangrene. What happens in gangrene? There is death of macroscopic portions of tissue. Why the color of gangrene is black? So the tissues are going to turn black. Why? Because there is breakdown of hemoglobin and there is formation of iron sulfide. So why the color turns black? Because there is breakdown of hemoglobin. So it is because of hemoglobin breakdown and there is formation of iron sulfide. So what happens? There is formation of iron sulfide. Iron sulfide. Iron sulfide. It affects most distal part of limbs. Why? Because in majority of cases it is because of arterial occlusion. So when it is occurring because of arterial occlusion, it affects most distal part of limbs. Most distal part. So most distal part of limbs. Most distal part of limbs. If it's because of arterial occlusion. So there are two types of gangrene. One is dry and one is wet. When gangrene is dry, here the tissue is dry and desiccated. It is dry gangrene. And when the tissue is moist, it is soft, it is swollen, it is wet gangrene. So how to remember? The gangrene is dry. Tissue is dry and desiccated. It's dry gangrene, and when tissue is moist, it is soft and it is swollen. It is wet gangrene. Now see the cause. What is the cause of dry gangrene? Usually, it is because of arterial occlusion, and this arterial occlusion is occurring over a long period of time. So what happens is the gradual slowing of blood leading to tissue desiccation. And you can see here the tissue is dry, you can see. It is dry and you can see it is desiccated. It is dry and desiccated. Mainly it is because of arterial occlusion. So there is slow gradual occlusion over long period of time. Here you can notice that there is a clear line of demarcation. Can you see here? This is the clear line of demarcation. So the line of demarcation, it is clear in dry gangrene, but here the line of demarcation is not very clear in wet gangrene. In dry gangrene, what happens? Bacteria fails to survive. But in wet gangrene, what is the problem? Actually, since it is because of venous occlusion, in majority of cases, there is venous occlusion. Apart from venous occlusion, there is super added infection. There is venous occlusion. Apart from that, there is super added infection. Because of this region, there are numerous bacteria. And that's why, can you tell me, the prognosis is better in dry gangrene or wet gangrene? So obviously, the prognosis is better in dry gangrene. Why? Because here, there is no associated sepsis. And because of sepsis, because of toxemia, here, the prognosis is poor. So in wet gangrene, there is poor prognosis. Poor prognosis. So these are common questions which are asked nowadays, the differences between dry gangrene and wet gangrene. So what is the site of dry gangrene? Lower limb, because arterial occlusion is more common in lower limb, especially in the distal part. It can be seen in upper limb also, but more common in lower limb. Wet gangrene, it is because of venous occlusion. It is more common in bowel. So this one, wet gangrene, this is more common in bowel. More common in bowel, usually small bowel. So it is more common in bowel. More common in bowel. Mechanism, there is arterial occlusion, and in dry gangrene, actually there is gradual slowing of blood. So because of gradual slowing of blood, what happens? Yes, it leads to tissue desiccation. So since there is gradual slowing of blood, there is tissue desiccation, right? Here, wet gangrene, it is because of venous occlusion. Apart from venous occlusion, there is venous occlusion. Apart from venous occlusion, there is super added infection. So these patients are having infection also. That's why we discussed that. Because of added infection or because of associated infection, prognosis is poor. If you see macroscopically, if you see the organ, we discussed just now, it is dry, shrunken and black, and there is clear line of demarcation between gangrenous tissue and the healthy part. But in wet gangrene, actually tissue is moist. That's why it is known as wet. So moist, it is swollen, it is moist, swollen, and it's dark. Dark. There is line of demarcation in dry gangrene, but there is a poor line of demarcation, or usually there is no line of demarcation. There is poor demarcation, or usually there is no line of demarcation in wet gangrene. In dry gangrene, bacteria fails to survive, but in wet gangrene, since there is super added infection, what happens? You are going to find numerous bacteria. Numerous bacteria. So because of associated sepsis or because of associated toxemia, here the prognosis is poor. Here the prognosis is poor, but in dry gangrene it is better. Now we are going to discuss amputation. First, see the indication. First, if the limb is already dead. So here what's the problem? Limb is already dead because there is gangrene. In this case, there is arterial occlusion, and arterial occlusion is severe enough to cause infarction of major part of tissues. So here the limb is already dead, you have to go for amputation. If it's a deadly limb means, imagine patient is having wet gangrene or there is spreading cellulitis. If you are not going for amputation, in this case, what will happen? The putrefaction as well as an infection. Putrefaction as well as infection, it can spread to the surrounding tissues. So limb is deadly. Patient is having AV fistula or patient is having malignancy. Because of this malignancy, what happens? It can lead to metastasis. So if limb is deadly, in that case also we go for amputation. Or whenever there is dead lost limb. What is this dead lost limb? In these cases, actually there is no proper function of the limb, and to improve the quality of life we have to perform the amputation. Suppose patient is having severe rest pain with unreconstructable critical limb ischemia. Patient is having paralysis with some complication. Patient is having contracture or trauma. So in these cases, to improve the quality of life, we perform amputation. So what are the indications of amputation? Dead limb, gangrene, deadly limb, wet gangrene, spreading cellulitis, AV fistula, malignancy, and dead lost limb whenever severe S pain is there with unreconstructable critical limb ischemia, paralysis, contracture, trauma. See the important points related to distal and transmetatarsal amputation. First, local amputation of digits, it can be done in the patients who are having diabetes mellitus. Why local amputation of digits can be done in the patients who are having diabetes mellitus? Because diabetes mellitus is going to cause small vessel disease with relatively good blood supply to the surrounding tissues. Second, in which cases we are doing ray excision. Ray excision is done when metatarsophalangeal joint is involved. If there is involvement of MTP, that is metatarsophalangeal joint, in that case we can go for ray excision. Now next is transmetatarsal amputation. So whenever there are involvement of several toes, when several toes are affected with adequate proximal circulation, in that case we go for transmetatarsal amputation. So in these cases when there is involvement of several toes, so when several toes are affected, several toes are affected with adequate proximal circulation, in these cases we are going for transmetatarsal amputation. Remember 3 points: local amputation of digits, diabetes mellitus; ray excision when there is involvement of metatarsophalangeal joint; and transmetatarsal amputation when several toes are affected. The two amputations which you have seen commonly in ortho also and in surgery also, one is below knee amputation, one is above knee amputation. There are advantages as well as disadvantages. First, see the below knee amputation. What is the advantage? That it is going to preserve the knee joint. Since knee joint is preserved, it gives the best chance of walking again with prosthesis. Here, how much should be the stump length? It should not be less than 8 centimeter. So stump length, it should not be less than 8 centimeter. So it should not be less than 8 centimeter, right? Generally, it should be 10 to 12 centimeter. So it should not be less than 8 centimeter. Generally, it should be 10 to 12 centimeter. Below knee amputation. Above knee amputation. Here, what's the advantage? That it is going to heal, more likely to heal. It is appropriate if in the patient there is no prospect of walking again. Suppose femoral pulses are absent. So obviously if femoral pulses are absent, you cannot go for below knee amputation. So it's done if femoral pulses are absent. If it's absent, femoral pulses, and here you have to remember that how much should be the stump length? It should not be less than 20 centimeter. It should not be less than 20 centimeter. So it should not be less than 20 centimeter. Guys, how to remember? Here, below knee amputation 10 centimeter, above knee amputation 20. So it should not be less than 8 centimeter if it's below knee amputation, and it should not be less than 20 centimeter it is above knee amputation. Now see the complications of amputation. If you have seen early and late complication, early complication you have seen there might be hemorrhage, there is collection of hematoma. And if there is collection of blood, that is hematoma, it can lead to infection. Because of infection, sometimes if it's not drained on time, it can lead to abscess. And sometimes if there is contamination because of fecal matter, it can cause gas gangrene. It can lead to gas gangrene. There might be wound dehiscence, there might be flap necrosis, and early complication is DVT. And because of this DVT, what happens? It can cause pulmonary embolism. Late complications. These patients are having pain. Can you tell me what's the cause? What are the causes of pain? The pain can be because of unresolved hematoma. Sometimes there is a bony spur. If you have seen, there is bony spur, or sometimes patient is having amputation neuroma. So what are the causes of pain here? Late complication. It is because of unresolved hematoma. Unresolved hematoma. Hematoma. Clear? It can be because of bone spur, or there is amputation neuroma that can also lead to pain. So what? Amputation neuroma. Amputation neuroma, right? There is one complication, yes, late complication, that is phantom limb. What is phantom limb? Patient still can feel the amputated limb. So phantom limb, when patient can feel the amputated limb, and if there is pain in that amputated limb, patient can feel the pain in amputated limb, so that is phantom pain. If patient can feel the limb, phantom limb, and in that limb which patient is going to feel there is pain, it is phantom pain. There can be stump ulceration, and what is the cause? It is because of ischemia. So these are early and late complications of amputation. Now see the leg ulcers, venous ulcers, arterial ulcers, neuropathic ulcers. See the characteristic features. First, what is the location of venous ulcers or varicose ulcers? Mainly if you see, it is located around medial malleolus. So mainly it is located around medial malleolus, and this region or this area is known as Gator's area. So what? This region is Gator's area, or this is known as Gator's region. So Gator's area or Gator's region, typically it is seen above medial malleolus, but it can be seen above the lateral malleolus also. So that is venous ulcer, also known as varicose ulcer. Arterial ulcer. What's the problem in arterial ulcer? It is caused by arterial occlusion. So can you tell me in which parts of body arterial ulcers are usually seen? It is seen in distal ends of limbs. Distal ends of limbs. So what are the typical locations? You can see the typical locations. It can be seen over shin of tibia, anterior shin. It can be seen over toe joints, under the heel, over the malleolus. So mainly in the distal part. Why? Because distal parts of limbs. Distal parts of limbs. Why? Because the cause is arterial occlusion. Next is neuropathic ulcer. It is seen over the bony prominences. So you can see here neuropathic ulcers. So these are seen over inner side of first metatarsal head, over the toe joints, under the heel, over the malleolus. So neuropathic ulcers mainly seen over bony prominences. So these are mainly seen over bony prominences, right? Bony prominences. We have discussed venous ulcers in venous disorders. We have discussed neuropathic ulcers in burn and plastic surgery. In this chapter, we will be discussing mainly the arterial ulcer. So first, tell me etiology. We discussed that there is impaired blood flow. So what will happen? Because of arterial occlusion, there is impaired blood flow. Because of that, there is ischemia. Because of ischemia, what will happen? Yes, it can lead to tissue death. And if there is tissue death, you can see the ulcer. You can see the image. You can see this ulcer, the image. What you can notice? You can notice that it's punched out. So because of tissue death, what kind of ulcer you are going to see, guys? Here, punched out. So here, patient is having punched out edges. Ulcer is having punched out edges. Another cause of arterial ulcer, diabetes mellitus. Why? Because you know that in diabetes mellitus, there is both microangiopathy and macroangiopathy. There is microangiopathy. There is microangiopathy. Diabetes leads to micro as well as macroangiopathy, both. Macroangiopathy. Because of this, what happens? These patients are having endothelial dysfunction. And since there is endothelial dysfunction, there is endothelial dysfunction. Because of this endothelial dysfunction, obviously there is impaired blood flow. So ultimately what will happen? Because of endothelial dysfunction, there is impaired blood flow, leading to ischemia, leading to tissue death, and ulcer is having punched out edges. We discussed that. What is the cause? Arterial occlusion. And you know one of the basic principle, whenever there is arterial occlusion, there is ischemia. And because of this ischemia, tell me, it is painful or painless? Intensely painful. So arterial ulcers, you can notice that it's punched out. You can see it's punched out. It's intensely painful. Since there is arterial occlusion, what happens? Distal pulses are usually non-palpable. Distal pulses are non-palpable. Another thing, you are going to notice the signs of ischemia, like there will be thin, shiny skin because of loss of subcutaneous fat. The muscle girth will be, there will be atrophy. So the girth of muscle will be lesser. What else? There can be lack of hair. So loss of hair and brittle nails. So it is associated with thin, shiny skin. Because of ischemia, there is thin, shiny skin, loss of subcutaneous fat is there. There is loss of hair. And you can notice that brittle nails, right? And in the past also, yes, if you are going to examine, if in the past patient was having gangrene because of arterial occlusion, you might be noticing that there is amputation of one or more toes. So these features are associated with arterial ulcers. In this case, how to make the diagnosis? See, in majority of cases, we make the diagnosis clinically, but sometimes you need Doppler. Why? Because you want to assess the flow. So since we want to assess the vascular flow, that's why Doppler is required. In majority of cases, we are going to make the diagnosis clinically? What's the treatment? Since there is arterial occlusion, so we go for revascularization procedure. Sometimes the ulcer is infected, and if it's infected, we have to go for debridement and we give antibiotics. So revascularization procedure, because there is arterial occlusion, infected ulcer, we go for debridement, and we give antibiotics. Clear? We give antibiotics. So this is how we manage the patients who are having arterial ulcers. AV fistula, tell me, it is mostly congenital or acquired? This is a very common mistake students are doing in exam. Guys, AV fistula is mostly congenital. So most commonly, AV fistula is congenital. You have seen some patients who are having local gigantism, in which suppose patients are having two toes, two thumbs. So one is relatively longer, relatively bigger. So that is local gigantism because of AV fistula. Some patients are having red colored patch. So because of AV malformation or AV fistula, you have seen many patients who are having patches, local gigantism. So it's congenital. Mostly AV fistula is congenital, and in majority of cases, it is not having any kind of symptom. So mostly it's congenital, most commonly. What is the most common cause of acquired AV fistula? Guys, it is penetrating trauma. So whenever there is penetrating trauma, there is communication between small arteries and veins, which is asymptomatic. So most common cause of acquired AV fistula, that is penetrating trauma. Guys, it is not iatrogenic, it is penetrating trauma, followed by iatrogenic. Iatrogenic means we are creating fistula for hemodialysis. So it is iatrogenic. So I'm repeating the question again. Mostly it's congenital. What is the most common cause of acquired AV fistula? It is penetrating trauma followed by iatrogenic. Now we are creating some fistulas for hemodialysis. What are the names? First is Braccia seminofistula. Guys, one thing is common between all these, that the artery is fixed. Which artery? In all these, the artery is radial artery. It is radial artery. Clear? So in all these, it is radial artery. Now how to remember the vein? Braccia seminofistula. It is C, seminofistula. So it is between radial artery and cephalic vein. It is between radial artery and cephalic vein. Braccia seminofistula, cephalic vein. Snuff box fistula, again, it is between radial artery and cephalic vein. Here, which branch of radial artery? This you have to remember. In snuff box fistula, we are using posterior branch. Which branch of radial artery? Remember guys, it is posterior branch. And Feinberg fistula, here you can see the B, Feinberg. So it is between radial artery and basilic vein. Between radial artery and basilic vein. So I hope you will remember. Braccia semino, cephalic vein. Snuff box also cephalic vein, but in snuff box we are using posterior branch of radial artery, and Feinberg B we are using basilic vein. So here fistula is created between radial artery and basilic vein. So prior to creation of AV fistula, we have to perform a test. What's the name? Modified Allen's test. Very easy, very important. It is asked in exam. So why we are going to perform this Allen's test? It is done to test the adequacy of blood supply to the hand from radial and ulnar arteries and arcade between them, right? So it is done prior to creation of AV fistula. So see guys how to perform this modified Allen's test. Patient is having clenched, blanched arm, and we are going to occlude this ulnar as well as radial artery. When patient is going to open the palm, we are going to release the ulnar artery. When ulnar artery is released, and you are going to notice that the hand is having normal color. There is return of normal color in the hand. It means ulnar artery is patent. And when ulnar artery is released, but what happens? The hand is still pale. So if hand is still pale, it means the ulnar artery is occluded. So whenever ulnar artery is patent, there is return of normal color. In the hand, there is return of normal color. And if hand is still pale, even after release of ulnar artery, if hand is still pale, so hand is still pale. Clear? So if hand is still pale, it means what happens? It is ulnar artery. Ulnar artery is not patent. It's not patent. What's the name of this test? Test is Modified Allen's test, and it is done prior to creation of AV fistula. Now imagine you created AV fistula between artery and vein. See the pathophysiology. So in this image you can notice that this AV fistula is created between this artery and vein. What will happen? Yes, the arterial blood, it starts going where? Into the vein. So when this arterial blood start going into vein, what will happen? There is increased venous return to the heart. And if there is increased venous return, what will happen? There is increased cardiac output, there is increased heart rate, there is increased systolic blood pressure. In comparison to systolic blood pressure, the diastolic blood pressure is not going to rise that much. So here, patient will be having wide pulse pressure. When there is fistula, you can notice that there is pulsatile mass. If you place your hand over the fistula, you can feel the thrill. Blood is going with force beneath your hand. So that is palpable thrill. So there is pulsatile mass, palpable thrill. And what will happen? In chronic cases, there are changes in the vein. What are those changes? The vein becomes dilated, it becomes tortuous and thickened, and this change is known as arterialization of vein. So in chronic cases, vein is dilated, tortuous and thickened. This is known as arterialization of vein. So this is known as arterialization of vein. Clear? This is the pathophysiology. This is very, very important. Imagine I'm going to occlude artery proximal to fistula. If I'm occluding artery proximal to fistula here, so what will happen if you are going to occlude it? Yes, pulsatile mass size decreases, thrill disappears, and heart rate, it is relatively decreased or it is going to normalize. So what? Pulsatile mass, P, pulsatile mass, size decreases, here size decreases, okay. So size decreases. What will happen to thrill? Thrill disappears, disappears. And what will happen to heart rate? Heart rate, relatively it is decreased or it's normalized. It is relatively decreased or normalized. Why? Because the moment you are going to occlude the artery, what will happen? Yes, now extra blood is not going into the vein. So what will happen? Now the venous return is normal. It means in this case, what happens? The heart rate will be normalized or relatively decreased. So how to remember? Mnemonic is PTH. What is the name of this sign, guys? It is known as Nicola-Doni or Branham sign. So occlusion of artery proximal to fistula leads to pulsatile mass size, decrease in size of pulsatile mass, thrill, it disappears, heart rate relatively normalized. So it is Nicola-Doni or Branham sign. How to make the diagnosis? Diagnosis can be made by angiography. It can be made by duplex scan also. So diagnosis can be made by angiography or duplex scan. What is the advantage of angiography? You know that it is diagnostic and therapeutic. What do you mean by therapeutic? Imagine patient is having small fistula, so we can perform embolization. So therapeutic means for small fistula, we can go for embolization. So you know the management now. If patient is having small fistula, we can go for embolization. But if large fistula is there, we go for surgical ligation. So treatment option, guys, for small fistula, embolization is the embolization, and for large fistula we go for ligation, surgical ligation. So large fistula we go for surgical ligation. Next condition is thoracic outlet compression syndrome. First, thoracic outlet compression syndrome, guys, is a misnomer. Why? Because here there is compression of subclavian vessels and nerves of brachial plexus, not at the outlet. This compression occurs at thoracic inlet. So this compression occurs at thoracic inlet. It occurs at thoracic inlet, not at the outlet. Now see the inlet and outlet. This region is inlet and this is outlet. So what happens here? You can notice that this is subclavian vein. You can see this red colored subclavian artery, and you can see this is brachial plexus, yellow colored. So these are the nerves of brachial plexus. So at thoracic inlet, what happens? There is compression of subclavian vessels and nerves of brachial plexus. Next, it is more common in males or females? Females. And in what kind of females? Middle-aged females. So more common in middle-aged females. This is more common in middle-aged females. Middle-aged females. Now see the types. Whenever there is compression of nerves of brachial plexus, this is known as neurogenic form. Whenever there is compression of vessels, either subclavian artery or vein, it is vascular form. Tell me which one is more common? Neurogenic form. And in neurogenic form, most commonly involved root value is CAT1. And obviously, this is for which nerve? Ulnar nerve. So two important questions. What are the types of thoracic outlet compression syndrome? Neurogenic form, vascular form. Which one is more common? Neurogenic form. Here, there is compression of nerves of brachial plexus, root value C8T1. So most commonly affected nerve, this is ulnar. Most commonly affected nerve, ulnar. Vascular form, there is compression of subclavian artery, or sometimes there is subclavian vein thrombosis. So there is involvement of subclavian artery or vein. Now, important point, in majority of cases, what happens? In middle-aged females, what happens? There is atrophy of shoulder girdle muscles, right? So actually, this compression is not static, it's dynamic. Dynamic means the compression is prominent in one particular posture. So compression at thoracic outlet of compression syndrome, it is dynamic compression. Dynamic compression means it is prominent in one particular posture. This compression, it is prominent in one particular posture. And since it's dynamic obstruction, that's why here radiological investigations are not very helpful. Here the diagnosis is made by provocative test. So it is best diagnosed by provocative test. So this is best diagnosed by provocative tests. Now you can see this thoracic inlet is already a compromised space, relatively narrow space. So anything which is abnormal in this area, anything which is extra in this area, it can increase the risk of thoracic outlet compression syndrome. Like patients who are having cervical rib, extra rib, patient who is having abnormal first rib or fibrous band. So if there is cervical rib, patients who are having abnormal first rib, so cervical rib, abnormal first rib, or the patients who are having fibrous band, patients having fibrous band. If there is long transverse process of cervical vertebra, which one? 7th cervical vertebra, osteoarthritis, Pancoast tumor. So Pancoast tumor arising from apex of lung, again this space will be compromised, and patients who are having cervical hematoma, again space is compromised. So these are the predisposing factors. Now coming to the clinical features, we discussed that which one is most common? Neurogenic form, most commonly involved nerve root value, C8 and T1. So the nerve involved, it is ulnar. It is ulnar nerve. Now guys, see the symptom. When there is involvement of this ulnar nerve, this patient is going to complain that, sir, I'm having pain and paresthesia over inner aspect of forearm and hand. Another thing, when you perform the examination, there is atrophy of these hypothenar muscles and interossei. So on examination, what we are going to find? There is pain and paresthesia over inner aspect of forearm and hand, inner aspect of forearm, inner aspect of forearm and hand, and on examination there is atrophy of which muscles? We discussed which one? Atrophy of hypothenar muscles and interossei. So atrophy of hypothenar muscle, it is hypothenar muscles and interossei. Clear? Interossei. Suppose there is arterial compression. If there is arterial compression, what will happen? There is pain, pallor, paresthesia. So because of arterial compression, there is pain, pallor, paresthesia. Pain, pallor, usually pain, pallor, paresthesia. And in some cases, there is occlusion of vein, or sometimes there is venous thrombosis. If there is occlusion of vein or venous thrombosis, what will happen? Here, there is collection of deoxygenated blood, and because of collection of deoxygenated blood, there is cyanosis, there is edema, there is pain. So in venous form, there is pain, cyanosis and edema. Clear? So there is pain, there is cyanosis and edema. So pain, cyanosis and edema. Clear? In the venous form. Now how to make the diagnosis, guys? We discussed that. See, if some anatomical abnormality is there, obviously you can make the diagnosis by radiological investigation, like cervical rib is there, Pancoast tumor is there. Yes, in these cases you can make the diagnosis, but we discussed that in majority of cases the obstruction is dynamic. It is prominent in one particular posture. So we are going for provocative test. What are the provocative tests used for diagnosis? Addson test, which is also known as Scaleni test, costoclavicular test, which is also known as military position, also known as Halsted test, hyperabduction test, that is known as Wright test, and Roos test, it is arm claudication test. One by one we are going to discuss. See the first one. So the first test is Addson test. It is also known as Scaleni test. In this case, first we are going to check the radial pulses. After that, we ask the patient to take a deep breath and hold it. So you can see here, we are going to check the radial pulses. Ask the patient to take deep breath and hold it, and after that extend the neck fully and turn the face towards the side. You can see patient is turning the face towards the side. If after this test there is obliteration or diminution of radial pulses, it suggests the diagnosis of thoracic outlet compression syndrome. So this is Addison test. Next is costoclavicular test. You can see what is the other name. It is also known as military position, also known as Halsted test. Here also, first we are going to check the radial pulses, you can see. And after that, patient is instructed to draw shoulders downwards and backwards. So you can see shoulder is downwards and backwards, and if there is obliteration of pulses or there is reproduction of symptoms, again it is suggestive of compression. So this is costoclavicular, also known as military position, also known as Halsted test. The third test is hyperabduction test. It is also known as Wright test. So the term is self-explanatory, hyperabduction. In this case also, first we are going to check the radial pulses. So after checking the radial pulses, you can see we are going to ask the patient to hyperabduct the arm. Where? Till 180 degree. So you are checking the pulses. Ask the patient to hyperabduct the arm till 180 degree. Clear? So you can see patient is going to hyperabduct the arm to 180 degree. After that, if there is obliteration or diminution of radial pulses, it means it suggests the diagnosis of what? Thoracic outlet compression syndrome. And the Roos test, which is also known as arm claudication test, this was asked in one of the latest exam. In this case, what happens? Ask the patient to draw the shoulder backwards, the arm should be in the horizontal position, and here the elbow should be at 90 degree, flex to 90 degree. After that, ask the patient to perform exercise with the hands. And whenever patient is performing the exercise with the hands, there is numbness or pain in the hands with exercise, it suggests the diagnosis of thoracic outlet compression syndrome. So this is Roos test, also known as arm claudication test. How we are going to manage thoracic outlet compression syndrome? We discussed that in majority of cases, it is neurogenic form. So in more than 90% cases, it is neurogenic form. And the patients who are having neurogenic form of thoracic outlet compression syndrome, these patients respond to conservative management. So first advice, there should be improvement in sitting, sleeping and standing position. Second, we advise patient for physiotherapy. So in physiotherapy, muscle stretching and strengthening exercises are being taught to the patient. What are the indications of surgical intervention? First, obviously, if there is failure of conservative management, means there is no improvement, or there is deterioration of symptom. Imagine there is progression of sensory or motor symptoms. If nerve is compressed, in that case, what you're going to notice, excessively prolonged ulnar or median nerve conduction velocity. If it's vascular form, guys, conservative management is not done in vascular form. So in vascular form, we have to go for urgent surgical intervention. So whenever there is narrowing or occlusion of subclavian artery, or there is thrombosis of axillary or subclavian vein, or patient is having some anatomical abnormality like cervical rib, fibrous band. So in all these cases, we go for surgical intervention. Now see what kind of surgical intervention is done. The patients who are having cervical rib or abnormal first rib, in these cases, we go for complete removal of first rib. Apart from complete removal of first rib, we perform division of scalenus, anticus and medius. So division of muscle, scalenus, anticus and medius. Scalenus, anticus and medius. So division of muscle, scalenus, anticus and medius. Second, if a patient is having large aneurysm or there is thrombosis of subclavian artery, in this case, we have to go for graft reconstruction. So the treatment is graft reconstruction. And if patient is having subclavian vein thrombosis, since there is thrombosis, so first stop thrombotic process. So we have to start thrombolytic and anticoagulant therapy. So first thrombolytic, clear? So thrombolytic and anticoagulant therapy, clear? And followed by surgical decompression. Simultaneous surgical decompression is done. So we perform surgical decompression. So this is how we are going to manage the patients who are having This is the surgical intervention or operation for thoracic outlet compression syndrome. And now we are going to discuss the questions, guys. See the questions. Here you can see a 40 years old, 40 years, see the age, male having long history of cigarette smoking, presented with gangrene of left foot. All these findings are suggestive of Burgess. Another thing, amputation of left foot was done. Representative sections from the specimen revealed presence of arterial thrombus with neutrophilic infiltrate wear in the arterial wall. Inflammation also extended into neighboring veins and nerves. So can you see here, there is involvement of artery, vein and nerves. What's the most probable diagnosis? Young male smoker, age around 40. So this is thromboangiitis obliterans. Obviously, what's the name? Burgess. So what's the diagnosis, guys, here? Here, patient is having Burgess disease. See this question, 25 years old male presented to OPD complaining of pain and numbness where medial aspect or inner aspect of right arm. Medial aspect or inner aspect of right arm. On examination, can you see the vesting? Vesting of thinner as well as hypothinner eminences, right? Abduction as well as adduction, abduction were restricted. Hand were cold and cyanosed. It means there is compression of vessels, compression of nerves. Radial pulses were diminished. Left hand appeared normal. One side. Chest X-ray revealed cervical rib. Clear? There is cervical rib. Which of the following is commonest feature? So first, guys, what is the condition? It is written thoracic outlet compression syndrome, and commonest feature, it is neurogenic form, and in neurogenic form C8T1 is the root value. So which nerve is involved? It's not the intermittent claudication, it's not the gangrene. There is pain in ulnar nerve distribution, root value C8T1, nerve, it's ulnar, so correct answer is C. So this is all about arterial disorders part 1.